named Individualized Target Volume Selection and Dose Prescription after Conservative Surgery, Mastectomy, and Reconstruction. Please.
Thank you, Mr. Chairman, and good morning. I'd like to thank the organizing committee for the invitation to speak at this meeting, and I'll do my very best to keep the time with this fairly large and complex topic. The progress that we have witnessed over the last few decades in individualizing radiation target volume and dose-fractionation is being enabled by the integration of the remarkable advances that we witnessed in terms of the radiation technology, as well as increasingly in-depth understanding of tumor biology and radiobiology, and all in the context of multidisciplinary care. And this progress is clearly demonstrated in the development of whole breast hypofractionation after conservative surgery. Conventionally fractionated whole breast radiation, typically 50 gray in 25 fractions, administered over 5 weeks, was commonly used in the earlier randomized trials of radiation after conservative surgery, on the basis that the 2 gray fractions spare dose-limiting, late-responding normal tissues, such as the cardiac, pulmonary tissues, more than the breast cancer itself. However, many years of investigations and radiobiological modeling showed that, in fact, hypofractionated radiation of greater than 2 gray per fraction, given over a shorter period of time, might be as effective as conventional fractionation. And therefore, since the 1990s and 2000, a number of randomized trials have investigated whether moderately hypofractionated whole breast radiation delivering 2.7 to 3.3 gray daily could yield comparable oncologic and cosmetic outcomes as the conventional fractionated whole breast radiation. And this table summarizes the major randomized trials of whole breast hypofractionation published over the last few years. The UK START-P, or the pilot study, and the UK START-A trials, there were 3-arm randomized studies designed primarily to generate the radiobiological data on local control and normal tissue effects, unconfounded by the overall treatment time. And as you could see, in all arms, the treatment in both the START-P and START-A trials were given over 5 weeks. And START-B, also a UK study, and the Canadian Oncoletter trial, there were 2-arm pragmatic design intended to test the non-inferiority of hypofractionated whole breast radiation, being 40 gray and 15 fractions over 3 weeks in the START-B trial, and 42.5 gray and 16 fractions also over 3 weeks in the Canadian Oncoletter studies. And over 7,000 patients were randomized to these 4 studies, and all 4 trials have published their long-term outcomes data. And as you could see, the UK START-B and the Oncoletter trials have confirmed the non-inferiority of hypofractionated whole breast radiation compared to the conventional fractionation. And in addition, in the UK START-B trial, the 10-year local recurrence rate with a hypofractionated radiation therapy was 3.8% compared to 5.2% with the conventional fractionation. This may suggest that there is a time effect for local recurrence after adjuvant radiation therapy for early breast cancer. And on the other endpoints of these randomized trials, the START-A study and the Oncoletter study showed that there was no difference between the treatment arms in terms of the 10-year mortality rate. But interestingly, if you look at the data for the START-B study, the 10-year distant relapse rates and the mortality rates were in fact lower in the hypofractionated radiation arm compared to the conventionally fractionated arm, and the differences were statistically significant. As you would have heard in the conferences, there remain controversies on the use of hypofractionated radiation in predominantly underrepresented or excluded patient subgroups, such as patients who are very young, being under 40, or patients who received novel systemic therapy, or patients who have larger breast sizes. Nonetheless, I think the randomized trials data that I've shown have indicated reliable level 1 evidence that breast cancer responds more strongly to fraction size than many other common cancers, and that hypofractionated whole breast radiation of 40 to 42.5 gray in 15 to 16 fractions given over 3 weeks is at least as safe and effective as conventional whole breast radiation for early breast cancer, and it's become the standard of care in many centers. And I think that considered application of a hypofractionated whole breast radiation provides clear socioeconomic benefits for patients as well as the health systems, as articulated in a number of guidelines in the UK, US, and in Australia. What are the limits of hypofractionated whole breast radiation? And this table shows the 2 UK studies, the FAST and the FAST-Forward trials, all 3-arm randomized trials. The FAST study was designed to inform the FAST-Forward study. The FAST-Forward study is a 3-arm randomized trial testing the 2 one-week schedules of hypofractionated whole breast radiation. The 2 test arms were 27 gray in 5 fractions given over 1 week, or 26 gray in 5 fractions also given over 1 week. And in future, I think these 1-week schedules of hypofractionated whole breast radiation may further improve the balance of local control and adverse effects and reduces the burdens of the conventionally fractionated radiotherapy. But of course, these are early days and much more work is required, especially in terms of the lead tissue toxicity. In some patients at a higher risk of local recurrence, the dose escalation to the tumor bed, commonly referred to as a tumor bed boost, is often given in conjunction with whole breast radiation therapy after conservative surgery. And this table summarizes the major randomized trials assessing tumor bed boost. In these trials, the boost doses ranged from 10 gray in 4 fractions to 16 gray in 8 fractions that were given after whole breast radiation, ranging from 50 gray in 25 fractions or 50 gray in 20 fractions. And only the ERTC trial has published their long-term follow-up data. As you could see, the local recurrence rates were significantly lower with the administration of tumor bed boost following whole breast radiation in both the ERTC, the Budapest, and the Lyon studies. However, tumor bed boost, although it did improve local control, but it's also been shown to significantly increase the rates of severe breast fibrosis, including the very long-term data published by the ERTC. And boost fractionation used in these randomized trials, as I've said, ran from 10 to 16 gray in 48 fractions. Then optimal dose fractionation at this point in time remains somewhat unclear. There are long randomized trials testing the boost dose fractionation question after whole breast radiation in patients with negative surgical margins, and at present, there are no data to show improvement in local control with higher boost doses in high-risk patients, for example, in the ERTC high-risk boost trial patients. And given the increasing use of hypofractionated whole breast radiation to reduce the overall treatment time and therefore improve patient convenience, the UK Import High trial involving over 2,600 patients compared sequential tumor bed boost after whole breast radiation versus the simultaneous integrated boost, or SIB, given at the same time as whole breast radiation. The intent is, of course, to reduce the overall treatment time and also improve patient convenience. And the simultaneous integrated boost was given using dose intensity modulation, a form of modern radiation technique, to vary the radiation doses according to recurrence risk across the breast, and that being highest in the region of the tumor bed. An early report of 3-year toxicity showed that they were similar across the 3 arms of the study, but efficacy data is pending. I'll now review the studies addressing the target volume question after conservative surgery in women with early breast cancer. And partial breast irradiation is an approach that is keenly debated at present, especially following the recent release of the results of a number of large-scale randomized controlled trials. And partial breast radiation presents an opportunity for integrating both the target volume question in terms of reduced target volume and the dose-fractionation question in terms of hypofractionation to improve the convenience of care. It limits the target volume to the tumor bed alone, where most of the local recurrences are observed, and it is this limited target volume that permits the self-acceleration of radiation delivery. And this table summarizes all the randomized trials of partial breast irradiation conducted since the 1980s, 1990s. And most of these trials, apart from 2, have released their efficacy and toxicity data. As you can see, there are large studies, predominantly involving over 22,000 patients in 13 randomized trials, and most of these patients had PT1, T2, and node-negative breast cancer. And a range of partial breast radiation techniques were deployed in these trials, including the external beam radiation, the interstitial brachytherapy, electrons, and intraoperative radiation using electrons of 50 kV X-rays. And a systematic review of the 6 randomized trials that were published before 2015 showed only 2 trials that were published, in fact, had 5 years follow-up. And a meta-analysis of these 2 trials with 5 years follow-up showed a higher local recurrence rate with partial breast radiation, hazard ratio of 4.5, but there was no significant difference in overall survival. And the severe toxicity, grade 3 or above, in these trials were low, less than 3%. And since the publication of the meta-analysis, a number of large, significant randomized trials have been published or presented. And one of these studies is the UK import law study, involving over 2,000 patients, 3-arm randomized trials. So as you can see from the figure, in the control arm, the whole breast received 40 gray in 15 fractions. In test group 1, the tumor bed received 40 gray in 15 fractions, while the remaining breast tissue received a reduced dose of 36 gray in 15 fractions. And in test group 2, only the tumor bed received 40 gray in 15 fractions, while the rest of the breast tissue received no radiation. And the import law study is unique in the sense that the same dose fractionation was used in all the groups of this study, and therefore the outcome differences is more likely to be due to differences in target volume rather than dose fractionation. And they reported a 5-year local recurrence rates, all being very low at 1% or less in all 3 arms, confirming the non-inferiority of partial breast radiation for local control. And the RAPID study was presented at the San Antonio Breast Cancer Symposium last December. It is randomized trials of partial breast radiation using 3D conformal radiation therapy in over 2,100 patients from Canada, Australia, and New Zealand. And the test arm of partial breast radiation of the RAPID trial deployed a dose fractionation schedule of 38.5 gray in 10 fractions given twice daily at least 6 hours apart. And at a median follow-up of 8.6 years, partial breast radiation was shown to be non-inferior to whole breast radiation in preventing local recurrence, with a 5-year rate of 2.3% in the partial breast radiation arm and 1.7% in the whole breast radiation arm. However, partial breast radiation was shown to be associated with increased adverse cosmesis, with 5-year rates of 32% in the partial breast radiation arm versus 16% in the whole breast radiation arm. And on this basis, the investigators of RAPID trial are unable to recommend the twice-a-day partial breast radiation regimen. And once-daily partial breast radiation using this technique may result in the same local recurrence without the significant increase in the adverse cosmesis rate. And this is a question that is yet to be tested, and a new study proposal is under development. And similarly, the much anticipated NSABP B39 RTOG 0413 trial was presented at San Antonio Breast Cancer Symposium last December. Now, this randomized trial was designed to determine if partial breast radiation provides equivalent local control compared to whole breast radiation. It's a large study involving over 4,200 patients, and in this study, the equivalency test was based on 50% margin of increase in the hazard ratio marked at 1.5. And at a median follow-up of 10.2 years, the 10-year rates of local recurrence was 4.6% in the partial breast radiation arm and 3.9% in the whole breast radiation arm. Note the very small absolute difference in the 10-year local recurrence rates between the two arms of 0.7%. However, the hazard ratio for local recurrence as first events was 1.22, with a 90% confidence interval from 0.94 to 1.58. And therefore, partial breast radiation, as defined in the protocol, did not meet criteria for equivalence to whole breast radiation in controlling local recurrence because of the upper limit of the confidence interval of hazard ratio. Therefore, in summary, there was a range of techniques, the target volumes, and dose fractionations that were used in the randomized trials reported or presented to date. And this does make it challenging to distinguish if outcome variations were due to differences in target volume or dose fractionation. However, current data do support the use of partial breast radiation for selected low-risk patients. Long-term safety and efficacy data are obviously essential for definitive evaluation of partial breast radiation. And I think that the current off-study application of partial breast radiation should be limited to low-risk patients defined by international and national guidelines. And the role of partial breast radiation requires further clarification. As we've heard from Dr. Whelan, selected low-risk patients may not derive meaningful benefits from radiation. I'll now briefly review the studies addressing radiation target volume and dose fractionation after mastectomy. As we've seen, the randomized trials demonstrating the efficacy of post-mastectomy radiation typically included the chest wall, as well as the comprehensive regional nodal radiation, including lymph nodes in the supraclavicular fossa, axilla, and the internal mammary chain. And therefore, the current evidence doesn't enable distinction of the relative contributions of the various nodal target subvolumes to treatment efficacy. And in Oxford overview of the 8 trials of regional nodal radiation without chest wall radiation showed that radiation reduced local regional recurrence, but not overall recurrence or breast cancer mortality, suggesting that chest wall is an important target volume. And of particular controversy is the inclusion of the internal mammary chain, or IMC, in patients with smaller axillary tumor volume. Note that the IMCs were included in 20 of the 22 trials of the Oxford overview showing the benefits of post-mastectomy radiation. And these French randomized trials showed that the inclusion of IMC in the post-mastectomy radiation volume did not significantly improve disease-free survival or the overall survival. We've heard Dr. Bartling briefly mentioning the Danish cohort study involving over 3,000 patients. And in this cohort study, patients with right-sided breast cancer were treated with radiation, including IMC, but not patients with left-sided breast cancer. And this study, in fact, showed a significantly lower rates of breast cancer mortality and better overall survival with the inclusion of internal mammary nodes in the radiation target volume. And the latest ESCO guidelines recommend that the IMC should be included in patients receiving post-mastectomy radiation for node-positive breast cancer. There are few data addressing the question of dose fractionation after mastectomy. The UK START trials were not powered for comparison of conventionally fractionated post-mastectomy radiation versus hypofractionated post-mastectomy radiation because of the small number of patients treated in this manner in these two trials. However, there was no increase in arm or shoulder dysfunction with hypofractionated post-mastectomy radiation, and no brachial plexopathy was observed after 40 gray in 15 fractions. And very recently published randomized trials from China testing hypofractionated post-mastectomy radiation versus the conventional fractionation in high-risk patients showed that hypofractionated post-mastectomy radiation was non-inferior to and had similar toxicities to conventionally fractionated hypofractionation after a median follow-up of almost 5 years. There are even fewer data addressing the question of radiation target volume and dose fractionation after breast reconstruction. And we know that integrating radiation after breast reconstruction is challenging because of the increased risk for late fibrosis and adverse cosmetic outcome. And at present, there are no guidelines for target volume delineation after reconstruction. And as we have seen in routine practice, the current techniques often include the reconstruction, either the implant or the autologous tissues in a target volume. And modern volume-based radiation planning may reduce the dose to these reconstructed tissues or the implant and potentially reduce toxicity. And the publication of the ASTRO consensus guidelines for contouring of the radiation target volume after reconstruction is pending. And as I've said, there is no high-quality data at present to recommend the use of optimal radiation dose fractionation after reconstruction. Therefore, any recommendation that you might have heard is primarily empirical. And fortunately, randomized trials testing moderate hyperfractionation after reconstruction are in progress. Therefore, in conclusion, I will say what I started with. There has been remarkable progress in local regional radiation in early breast cancer over the past 4 decades. And I think that the future in individualized local regional radiation will be enabled by integrating a growing understanding of tumor biology and radiobiology with advances in radiation technology. And I must emphasize that multidisciplinary collaboration is absolutely critical for driving this progress. Thank you very much.